So my topic is an extension of the previous discussion. So it's about the role of triple therapy in CHIP patients. So CHIP patients, we know they are a high-risk subgroup and they are more prone for ischemic complications. But at the same time, elderly, many CKD patients, so they are at a high risk of bleeding complication also. And as aging, the incidence of atrial fibrillation increases, so we need anticoagulation along with dual antiplatelet therapy. So how will you manage these issues? So concurrent use of oral anticoagulation and dual antiplatelets, it is theoretically necessary in this subgroup of patients. One is in atrial fibrillation patients who is already on anticoagulation, who is undergoing a complex CHIP procedure, or a patient who has undergone a CHIP procedure, develop atrial fibrillation, and we need triple antiplatelet therapy, anticoagulation along with dual antiplatelet therapy. And there is another subgroup, which is DVT patients undergoing a CHIP procedure. So 1/5 of patients of AF undergo PCA any time point in their lifetime. And 1 in 12 patients who undergo PCA, they develop AF at any time in their lifetime. So this group of patients, they are at higher ischemic risk and higher bleeding risk. So triple antitherapy put them at a higher risk of bleeding. So who are the best candidates for triple therapy? And when triple therapy is used, how long should we prescribe a triple therapy? And are newer anticoagulants superior to vitamin K antagonist? And which is the best antiplatelet agent after triple therapy as a part of dual therapy? And how can we minimize thrombotic and the bleeding risk? And is a single and oral anticoagulation alone is enough in the chronic phase, that is after the recommended 1 year after an angioplasty? So this is the evolution of DAPT over the years. So with time, we moved on to stronger antiplatelets. Ticagrelor came. Clopidogrel, we are concerned about the resistance. Then the ticagrelor and prasugrel when we came. And most of the high-risk ischemic patients, we prefer to use ticagrelor and prasugrel. And the newer generation of stent, they minimize the risk of bleeding, so we are more comfortable with using more of stronger antiplatelet agents. And the same time evolution is happening in the treatment of atrial fibrillation also. So the lesser number of vitamin K antagonists are more number of use of newer anticoagulants. So we have data with dabigatran, rivaroxaban, apixaban, and edoxaban in atrial fibrillation, and they almost replace vitamin K antagonist in the stroke prevention protocols. And there are 5 trials which change the concept of triple therapy. That is, the first one was the WOS trial. So that compared the vitamin K antagonist with clopidogrel and dual therapy versus triple therapy, and they found that the bleeding risk is lesser with dual therapy compared to triple therapy. And the other 4 trials which came, a redual PCA trial which used dabigatran, Pioneer AF PCA trial which used rivaroxaban, Augustus trial which used apixaban, and Entrust AF PCA trial which used edoxaban. So we have enough data now whether dual antiplatelet therapy is superior to triple antiplatelet therapy, and which agent we should use when you are using a dual therapy or a triple therapy, which antiplatelets will be the preferred one, which anticoagulant will be the preferred one. So these are the 4 trials. One is Pioneer AF trial which used rivaroxaban, but they used a lesser dose, not the standard dose of stroke prevention. Redual PCA trial which used 2 dose, dabigatran 150 mg BD and dabigatran 110 mg BD. Entrust trial which used edoxaban 60 mg and in selected patient 30 mg. And Augustus trial which used apixaban. And out of the 4 trials, apixaban, the Augustus trial is the largest trial, and that used the correct methodology. It was a 2 factorial design, which compared dual therapy and even with or without aspirin. And should we have enough data on CHIP patients? And these are from the subgroup analysis of the ReDual PCA and Pioneer AF data. And the subgroup analysis showed that the treatment effect of rivaroxaban or dabigatran, they did not vary when stratified by the location of the culprit artery, presence of bifurcation lesion, presence of thrombus, type and length of the stent, and number of stents. And there was no interaction between complexity of coronary lesion and the effect of rivaroxaban or dabigatran in the efficacy outcome. So from these trials, we can come to certain conclusion. That is DAT, dual therapy with an oral anticoagulant plus a P2Y12 inhibitor is a better alternative to triple therapy. In the absence of contraindication, NOAC should be used than the vitamin K antagonist. And specific agent should take into consideration the profile of the patient. That is the patient who was studied in the trials, or what is the profile of the trial patient which we are dealing with. And also should be based on the availability, cost, convenience, patient preference, and the physician preference. And almost always consider switching the patient, VK, to switching to a NOAC in the absence of specific indication for VK. And these are quite limited. That is in mechanical prosthetic valve, when there is an LV thrombus, moderate to severe rheumatic mitral stenosis, and antiphospholipid antibody syndrome. All the rest of the patients, we can safely shift to newer anticoagulants. And DAPT with aspirin and P2Y12 inhibitor is the cornerstone of therapy. And all patients should be on aspirin in the peri-PCA period. Clopidogrel is the P2Y12 inhibitor of choice, as it was used in most of these trials. 88% of the patients, they were using clopidogrel. Other alternative is ticagrelor, because the rest of the patients, they were on ticagrelor. And when ticagrelor is used, aspirin use should be confined to peri-PCA period. And usefulness of antiplatelet function testing and genetic testing to guide, not widely studied, but we should really consider. Reduction of bleeding complication with the dual versus triple antiplatelet therapy. And so in short, we prefer for shorter duration of triple therapy. And clopidogrel is the preferred antiplatelet. And NOAC is the preferred anticoagulant. And always use proton pump inhibitor for gastroprotection when we are using triple therapy or combination. And use some risk assessments tool. We have the chart score or Hasblot score. And the newer risk score model is from the ReDual PCA ACL trial. And they found that those who are at a higher risk and use the triple therapy in the peri-PCA period, which extend to 1 month. Otherwise, we go for a shorter duration only during the hospital, or maximum 1 week. Just 1 minute. So the preferred antithrombotic strategy will be, a default strategy will be a triple therapy in the peri-PCA period, which is during the hospital admission till the time of discharge, or maximum of 1 week. And double therapy up to 12 months, which include preferably clopidogrel and a newer anticoagulant, or you can use ticagrelor also. And patients at high ischemic and thrombotic risk and low bleeding risk, triple therapy during 1 month period, and double therapy for the remaining 12-month period. And patients at low ischemic risk and very high bleeding risk, triple therapy only during the peri-PCA period, and dual therapy up to 6 months, and after 6 months, oral anticoagulation alone. And after 12 months, the general patients, oral anticoagulation alone is prescribed, no antiplatelet. This is from the AFFAIR trial, which compared patients who are on rivaroxaban or rivaroxaban plus warfarin after 12 months of a PCA. There was no reduction in the ischemic events with the addition of aspirin. So this is in short the triple therapy. And the use of triple therapy as time goes on, it's going down, and the dual therapy is taking up the role. And in a PCA, we should consider the pre-procedural consideration, define the appropriateness of PCA, ischemic and the bleeding risk evaluation. And during the PCA, vascular access radial is preferred, and proper selection of patients, proper stent selection, and use of IVs to get an optimal result, which will reduce the ischemic risk. And in the post-procedural period, consider mourning and reassess the ischemic risk as the time goes on. and recommended use of PPI and avoid NSAIDs when we are on dual therapy or triple therapy. So the questions are answered. Triple therapy is beneficial only in patients at high ischemic and low bleeding risk, and beneficial in the peri-period till 1 month maximum. Normal risk score should be used to predict ischemic and the bleeding risk, and NOAC is superior to vitamin K antagonist in most of the cases. Clopidogrel is the preferred P2A12 inhibitor in triple therapy and in dual antiplatelet therapy, and in the chronic phase, single oral anticoagulation, but in CHIP patients, we may not recommend that drug. We may need to continue a single antiplatelet. And one size does not fit in with all. We need to consider the patient factors and the procedural factors, everything into account when taking this decision. So the conclusion is same. The answers which I have already told from the data. All this, now there are enough data to support all these recommendations. So triple therapy is very aggressive and carries high bleeding risk and death than the dual therapy, and no trade-off in efficiency. So in patient with high ischemic risk and low bleeding risk, anticoagulation plus 2 antiplatelet drugs can be given for a maximum of 1 month. And discontinue antiplatelet, and when you discontinue, use aspirin, because there is good data from the Augustus trial. They discontinued aspirin. So it was a comparison between aspirin and placebo. And risk score should be used to determine patient thrombotic and the bleeding risk. Thank you for all.
Thank you, sir, for the nice talk. So when you give a triple therapy initially in the procedure period, how much the dose of aspirin, clopidogrel, and
aspirin is the loading 325 milligram and 75 to 100 milligram daily only. And this is recommended during the peri-procedure period, because all these 4 trials, there was a phase where the randomization happens after a few days. So it was 3 to 5 days or maximum 7 days. After that, it was dual therapy. Aspirin was withdrawn.
Aspirin 150 or?
Aspirin 75 to 100.
75. Aspirin was 75.
75 to 100 milligram.
And when you change the triple therapy to double therapy, will you increase the dose of?
No, same dose is continued. And that is the one, this one. If you use rivaroxaban, ideally we should use the same dose for stroke prevention protocol. But in rivaroxaban, there is a trial which used lower dose, 15 milligram daily. So maybe even we can consider that dose. But after 6 months or 12 months, when we shift to oral anticoagulation, we should go to the full dose. But if you are using apixaban, that was a standard use used in the studies. So we can continue with 5 milligram daily, and dual therapy period 5 milligram daily. And when you discontinue the antiplatelet and continue oral anticoagulation, it is 5 milligram BD. Same dose. Twice daily, same dose.
Question from the audience.
Yeah, so this is slightly off topic here, but suppose a patient who's already had stroke and he's on single or dual antiplatelet, and he is detected to have a new onset AF, and then we are supposed to modify the regimen, like it's...
Considering the data, the preferred strategy will be single antiplatelets with an anticoagulation. If there is an indication for anticoagulation, separately. That is, it is a thromboembolic risk.
So just like we stopped antiplatelets after a year, that doesn't translate in case of stroke patients.
Stroke, I think that the single antiplatelet may need to...
That is the one which I was told. Even in CHIP patients, after 1 year or after 6 months, we may prefer to continue aspirin, but there are no data which shows that it is good. We may need to prospectively evaluate in studies.
I think decision has been made easier with the current generation of stents also. That has made life easier. And something which we can adopt is continuing only oral anticoagulant or a NOAC after 1 year.
After 1 year.
We've still not adopted.
That is the recommendation.
Correct.
Now, consensus recommendation on use of combination of anticoagulation plus antiplatelets.
Thank you. I think we will move on.
Thank you.